at a wavelength of 4,260 nanometers. So to make it simple, there are two parts to the capnograph or capnometer. There's a light source which will emit infrared light, and there's a sensor which will read how many of that light passes through. So when carbon dioxide is present, it will absorb the light, and the sensor will then sense how many of the light is, is absorbed again. Okay. There are two main types of capnograph: the mainstream or non-diverting capnograph and the side stream. The diverting capnometer transport a portion of the patient's expired gas from a sampling site, and then will need to pass through a sampling tube to a distant sensor. Therefore, there will be a slight delay in your capnograph reading. Okay. Beside the slight delay, it's also vulnerable to humidity or water. So, but it is light and can be used in patients that are non-intubated. Some face masks or nasal cannula have integrated ports where you can place the side stream capno. Okay. The parts of this is actually disposable, so you don't need to worry about sterilizing it. While the mainstream is quite bulky, so you need to worry about it if your patients are pediatric patients with ET tube size 3, okay, and mainly used in intubated patients. So how do you produce the waveform? I will again illustrate some of the physiology. The gas that you exhale will first come from the anatomical dead space, which is the part where there's no gas exchange, so the trachea. The CO2 content here is negligible. As you can see, it's at baseline of 0. And then the next gases that you will exhale are from the alveoli, a mixture of gas from the anatomic dead space and the alveoli. So you will see a rapid upstroke of end-tidal CO2 levels. And then it will eventually come to a point where all the gases are from the alveoli, and it will plateau. The end of that plateau is called the end-tidal carbon dioxide, where the level is at the maximum. Okay, and then you inhale, so carbon dioxide again will decrease. So you have two angles. Later I will elucidate the clinical significance of each. Recap. So from the first phase, the gases from the anatomical dead space will be exhaled first. No CO2 or very negligible. Next would be a rapid upstroke from the gases of your alveoli and a mixture of the gas in the anatomical dead space. And then from the alveoli purely, and then you inhale. The normal shape of the capnograph is said to be a top hat shape. That's the only normal shape, or a sine wave, which is basically the same shape. Okay. In the next few slides, I will correlate it clinically to what we see in the operating room. Okay. I placed the normal shape of the capnograph on the right side of the screen as a reference. You see, if you've noticed in this graph, the first phase or doesn't return to baseline, it's not 0. So that means there is rebreathing, and the causes of this are either a very low oxygen flow or gas flow, or an exhausted carbon dioxide absorbent. It can be also due to an incompetent expiratory valve. Okay, the next is where the alpha angle comes in. It's the angle between phase 2 and phase 3, which is located in the expiratory phase. It's usually placed at a 100 to 110 degree. And as you can see in the next pictures, There is a progressive slanting and prolongation of the expiratory upstroke. So the alpha angle increases. This is indicative of obstruction to gas flow. You can see this in either obstructed endotracheal tube or obstructed LMA, or due to obstructive lung diseases like asthma or COPD. So to make it simple and more photographic for you, that is the normal shape of the capnograph, and this is the shape of an obstructed airway, shark's fin. Move on to the beta angle, which is located in the inspiratory phase, which the one in the violet box. Normally, it is approximately at 90 degrees. And the angle, such as here, will be increased in the event of an incompetent inspiratory valve or rebreathing. So you can check your machine. If you've checked your machine beforehand and it malfunctions in the middle, you will know. Okay, the next, you see a cleft here, usually on the lateral third of the waveform. This shows small breaths at various, at, while the patient is mechanically ventilated, there's an effort to breathe. So it's time to top up your neuromuscular blocker. Or if it's at the end of your procedure, you can start your reversal. This is a picture of a patient trying to breathe while you're mechanically ventilating him or her. So either deepen your patient or top up muscle relaxants. A leak in the sampling line will show like this. There is a plateau of long duration followed by a brief peak, and the size of the peak is inversely proportional to the size of the leak. Okay, so you check the sampling sites. How about the pattern of the end-tidal monitor, the capnograph waveforms? What if it's like your measurements was 38 and then suddenly dropped to 0? You'll need to check your breathing system. Might be there's a disconnection, most likely. Or maybe the patient woke up and bit the tube, so there's complete obstruction of the endotracheal tube. Or it can be that your sampling line is plugged completely, so 0. How about if it dropped, but only slowly and not to 0 levels? The events that can cause this are sudden hypotension. You look at the field, maybe there's a massive blood loss going on, or an impending circulatory arrest. And it can be a pulmonary embolism, but if the embolism is a carbon dioxide embolism in laparoscopy, there might be a transient increase first before it drops. So this is my last slide. Thank you.